Today we're going to talk about a condition that is so common, it is practically a universal part of the human experience if you live long enough. We're talking about seborrheic keratosis. Technically, these are benign skin neoplasms composed of immature keratinocytes. While that sounds complex, these are the lesions often known to our patients by much simpler names, such as age spots or wisdom spots. Clinically, these lesions are encountered especially often in adults and older individuals. In fact, seborrheic keratoses occur in nearly 100% of people over the age of 60. For this reason, they are among the most frequently observed lesions in everyday clinical practice. The main challenge is usually not detecting them, but rather identifying them correctly so that patients can be reassured, while also recognizing the situations in which further investigation is needed. In terms of clinical presentation, seborrheic keratoses may show a range of appearances, but most share several classic features. They are typically described as stuck-on lesions, meaning they appear as though they have been pasted onto the surface of the skin. They are usually well-defined, and their surface may be hyperkeratotic, scaly, or waxy. Their color may vary from skin-colored to tan, brown, or black. Some patients present with only one or a few lesions, whereas others may develop many, sometimes even hundreds. In most cases, the diagnosis of seborrheic keratosis is mainly clinical. In other words, seborrheic keratosis is usually recognized on the basis of its characteristic appearance. If needed, dermoscopy can help support the diagnosis. Typical dermoscopic findings include comedo-like openings, milia-like cysts, gyri and sulci, and hairpin vessels. These findings are useful in distinguishing seborrheic keratosis from other pigmented or potentially suspicious skin lesions. However, if the lesion does not look typical or if there is any uncertainty in the diagnosis, then a biopsy should be performed, followed by histopathological examination. This is especially important when we need to rule out malignant lesions. The most important information for the patient is that seborrheic keratoses are benign and slow-growing. As a result, they usually do not require treatment for medical reasons. However, removal may be requested if a lesion becomes itchy, chronically irritated, or cosmetically bothersome. When treatment is indicated, the first-line option for superficial seborrheic keratoses is liquid nitrogen cryotherapy. This method is often preferred because it is quick, widely available, and does not require local anesthesia, making it highly practical in the outpatient setting. Another treatment option is electrodesiccation and curettage. This is particularly useful for large or thick lesions. However, it does require local anesthesia and carries a higher risk of scarring compared with cryotherapy. A further option is laser ablation. This may also be effective, although its use may be limited by cost. In summary, seborrheic keratosis is a common benign epidermal neoplasm seen mainly in older adults. It typically presents as a well-defined, stuck-on, pigmented lesion, and diagnosis is usually made clinically. Since the condition is benign, treatment is generally unnecessary unless the lesion is symptomatic or causes cosmetic concern. When treatment is required, cryotherapy is usually the preferred first-line approach. Overall, recognition of seborrheic keratosis is important because it allows appropriate patient reassurance, helps avoid unnecessary concern, and supports differentiation from more serious skin tumors.